My objective of making this video and giving you this information is to discuss the real-life repercussions of repeated doses of rifaximin given for a diagnosis of SIBO, and to also offer options to the herbal therapies and to the prescription antibiotic therapies. The study that we're about to look at is not a rare finding in my practice. It's not an isolated case. It's something I see a lot. In fact, the majority of my patients have failed rifaximin and have had several SIBO tests. I see people like this every day. I've seen thousands of them. I've seen them statewide, nationally, and globally. This particular patient is in Washington State. She is a 57-year-old female, and she has comorbidities of breast cancer and melanoma. She's married, she's retired. She uses Zyrtec for allergies and meloxicam as needed for pain. She has a history of childhood constipation. Her symptom onset in 2018, and it started with alternating constipation, diarrhea, and bloating pain, bloating, gassy pain. So let's stop there and think this through. And this is what I do with every patient. Alternating constipation, diarrhea, what can be the causes? Well, this is motility and peristalsis. It can happen when you use laxatives too much, where you clean yourself out and then you can't go for a while. It can happen because of a food intolerance. You eat it, you get diarrhea or constipation, you stop eating it, it goes away, back and forth if you don't know what food is impacting you. And then the bloating and the gas pain can be caused by either SIBO, small intestinal bacterial overgrowth, SIFO, small intestinal fungal overgrowth, dysbiosis in the large intestine, and also from constipation. Constipation can give you a lower abdominal bloating feeling because you just need to evacuate. So once food is ruled out as a cause of these symptoms, because for some people you're going to say, oh, try not eating dairy or try not eating wheat, and they'll stop eating those things and everything goes away and you're done. They don't need antibiotics. But once you've ruled out food, if the symptoms are still there, then you're going to want to look at what is fermenting. Is it a bacteria? Is it a fungal species? Is it both? This particular woman went to many different doctors, and she tried herbal antimicrobials. She tried oregano, allicin, berberine compounds. She tried motility agents, both herbal and prescription loperamide. She tried biofilm agents, herbal and compounded, and she had some imaging done. So 2017, she had a colonoscopy before all this started. It was normal. In 2019, after the symptoms started, she had an abdominal ultrasound and a CT scan. Those were both normal. In 2019, she also had a gastric emptying study. That was normal. In 2020, when she was in the midst of her discovery, she'd had a food panel done, and that was also normal. So in 2019, a year after diagnosis, she saw her first SIBO specialist, and she took a SIBO test, and she was positive for methane and hydrogen gas production. That's all we know from the SIBO test. We know the gas production. We don't know what's really going on. So she was given rifaximin and neomycin, antibiotics together, and she took those for the 14-day course. She improved somewhat overall. They didn't completely resolve her symptoms, but she did feel better. And then her symptoms came back after 2 months with a vengeance, which is not really unexpected because the relapse rate after Rifaxamin is 45%. Almost half the people that take it will relapse. And also the efficacy of the treatment is not that great. Rifaximin's ability to resolve symptoms is between 61 and 78%, and that comes from Yale Medicine. So she goes back to the doctor. She does her second SIBO test. She's still positive for methane and hydrogen gas production. So she's given a second course of rifaximin and neomycin, and this time she improved a little bit less and for a little bit shorter duration until her symptoms came back. So let's stop there. Why didn't it work as well? Was there some kind of mutation to cause a bacterial resistance? If we're treating the same species with a second course of antibiotics and we've really got the right target, then wouldn't she be a lot better? I don't think you're going to get bacterial resistance after a 14 day course, so that can't be what's happening. But her symptoms return just as bad as pre-treatment levels. So if the cause is the targeted bacterial species, can't we reason that the second course of Rifaxamin would result in improved or at least equivalent results? Are we on the right track? She goes back to the doctor. She does a third SIBO test. She's positive for methane and hydrogen species. This time they decide to try Rifaxamin paired with metronidazole antibiotics. And this time she improves a little overall for about 4 weeks. Symptoms come back. She goes back to the doctor. This time they don't test her. They assume that it's going to be the same. And they decide to do Rifaxamin and erythromycin, different antibiotic. And this time she improves a little again over 4 weeks, and then the symptoms come back. So when I meet this patient, she's actively waiting for her 5th course of Rifaxamin to be shipped to her. Let's just stop there and look at the principles at stake. Is SIBO really the cause of what's going on here, or is it the result? If it was the cause, wouldn't the antibiotics take care of it? Is the SIBO test even accurate? Dr. Joshua Goldenberg, naturopathic physician, does a very good analysis on the accuracy of the SIBO test. And that's you can see that on his YouTube channel, and his rating is pretty low. It's not a very accurate test. And we already know that 30 to 50% of the healthy adult population produce methane gas when they do a breath test. So just because you produce methane gas, does that give you an accurate diagnosis for a problem? No, because you might be one of the 50% or 30% of people that just normally produce it, and you're fine. Let's also look at some principles of medicine. Are we doing no harm? We don't know. Are we using the healing power of nature? No. Are we identifying and treating the cause? We hope so. Are we treating the whole person? Are we doing no harm? We don't know. Are we using the healing power of nature? No. Are we identifying and treating the cause? We think we are. Are we treating the whole person? Are we practicing disease prevention? And let's now examine Rifaxamin a little more closely in terms of how it maintains the diversity of the colonic species. So Rifaxamin works by inhibiting RNA protein synthesis in susceptible bacteria. It binds to the beta subunit of bacterial DNA-dependent RNA polymerase enzyme called RPO beta. The binding blocks translocation, which stops protein transcription and is thus lethal to the species. What bacteria use the RPO beta pathway? The majority of them. Anaerobic, aerobic, gram-negative, gram-positive. It's a broad-spectrum antibiotic. So how did we get here as this treatment for SIBO being Rifaxamin plus some other antibiotic? It started out with hepatic encephalopathy was what the original development of Rifaxamin was for, because it targets E. coli specifically, and so it helps these people who have this condition who need to get rid of the E. coli because it produces ammonium and backs up in their system, and it's lethal. Then it started to be used for traveler's diarrhea, and that seemed to be effective as well, but that again was a one and done, not a repeated course. And then it was postulated by a doctor named Mark Pimentel to be a treatment for IBS-D diarrhea. And it can be a great treatment for that as a one and done. Doesn't work, move on to the next thing. But also